So I just want to say very, very much welcome to our first HDR UK joint with ADR webinar program, trying to bring together people who are working and bringing together administrative data and health data. And so our first session today is with Ruth, who is the lead in understanding inequalities in the MRC Social and Public Health Science Unit up in Glasgow. And she's co-lead in the School of Health and Wellbeing of Data Science Research. Her expertise is on methods of evaluating complex interventions, very much natural experiments, which is how I know of her, and the development and application of multi-level modelling methods. She works closely with colleagues in Brazil on environmental determinants of health inequalities, and today she's going to tell us about her work on leading the Maternal and Child Health Network. I'd like to hand over to Ruth now to tell us a lot about MatCHNet.
Thanks very much, Sinead. So, yeah, thanks very much for your introduction, Sinead, and also thank you for inviting me to come and talk to your group today. Sinead asked me to talk about the Maternal and Child Health Network. It was funded by the UK Prevention Research Partnership, and really it was funded with the purpose of forging new collaborations. And over the past 5 years, we've worked really quite hard to build the network, and we're now a multidisciplinary community of public health researchers, methodologists, and some policymakers and advocacy groups are also members of MatCHNet. And what I'm going to focus on in this presentation is sort of why was there a need for MatCHNet? What activities did we do over the 5 years, and where do we go now? So the starting point really was to establish sort of approaches, tools to evaluate upstream policies that impact on maternal and child health using administrative data. And I think maybe the first question is like, why was there a need for this? So why invest in early years to improve adult health and reduce inequalities? Well, having a good start in life during pregnancy and infancy has been shown to be important for both living a healthy life and a longer life. We know that health and well-being during the early years has a crucial impact on chronic diseases and inequalities, both across the life course and also from one generation to the next. There's evidence about the impact of intrauterine and infant growth, preterm birth on cardiovascular health. And also the determinants of infant and child health, they're sort of complex, interrelated, and they range from family socioeconomic circumstances, childcare settings, neighbourhood deprivation, through to sort of pollution and other factors. There has been something called the First 1,000 Days Initiative, and that's influenced health policy sort of across the world, including in the UK. A recent UK parliamentary review took evidence about it, and the idea really is that those first 1,000 days, sort of from conception to age about 2, it's a period of rapid growth, and what happens during this time can lay the foundation for future health and development. It might not be new for people if you're already working in the area of infant and child health. You might have already be quite happy with all of this, but recently, over the last sort of 5 to 10 years, it's got more traction, as Michael Marmot had it as one of his recommendations in the Commission for Social Determinants of Health. And this graph on the left-hand side from research by James Heckman, that shows that the highest rate of the highest rate of economic return come from the earliest investments in the life course. So the economic benefits of investing early and also throughout childhood will provide greater success to more children, and therefore you've got greater economic productivity and reduced spending for society as a whole. There's also been a real willingness from governments to invest in the early years. We know that there's many governments, not just in the UK, they've got strategies and policies in place for the early years. There have been some evaluations of early years policies. So for instance, in Manitoba in Canada, they had a programme for low-income pregnant women and then for their children. this had sort of minimal effects on outcomes, but there were some positive benefits for one of their subgroups. In Sweden, they evaluated the SOLU programme, which was looking at health visitor contacts. It was the sort of effectiveness of a universal health promotion intervention, and they found limited positive impact on child and maternal health outcomes. And they're going to actually continue to follow them up to look at longer term outcomes. In Scotland, they introduced a baby box for all newborns. It contains things that are needed in the first few weeks, sort of nappies, nappy bags, cotton wool, baby grows, etc. This has been a policy in Finland for about 80 years, but when it was introduced in Scotland, we didn't really know what the effect on outcomes were. And there are other policies in the UK, such as enhanced provision of early years childcare, Healthy Start vouchers, and there was a previous universal policy called the Health and Pregnancy Grant, which was in place for about 2 years for all pregnant women. So as I said, there's this willingness to invest in policies with the aim of improving early years experience, but how do we know if these policies are working? A real challenge, I think, for policy is what works, and I suppose for who, in what circumstances, and also if it's maternal and child health we're thinking about, at what stage of the life course should these policies be introduced and what works when. So although we've got these policies in place and there's a willingness to invest, there have been very few outcome evaluations of the policies, and this is despite the House of Commons report on health inequalities, which was published in sort of 2009, 2010, and they stated there is this ethical imperative to develop and use evidence-based policy. All the reforms that they've discussed are experiments on the public, and they can be as damaging in terms of unintended effects and also opportunity costs as unevaluated new drugs or surgical procedures. So they go on to say that such wanton large-scale experimentation is unethical, needs to be superseded by a more rigorous culture of piloting, evaluating, and using these results to inform policy. And then they do go on to bemoan the fact that when evaluations are carried out, they tend to be process evaluations and not outcome evaluations, so they're not evaluating the effect on the outcomes that they're supposed to be having an effect on. So our vision for MatCHNet really is to produce that rigorous research evidence. So we were laying the groundwork to conduct these evaluations. So we want to, over time, produce this rigorous research evidence about early years policies to enable decision makers to implement the best policy options to optimise child health. The network, as I say, was funded with the purpose of forging these new collaborations. So MatCHNet is already a multidisciplinary community of public health researchers, methodologists, policymakers, and advocacy groups. And really sort of to make progress towards the vision, we needed to establish the approaches and tools to evaluate these upstream policies that can impact on maternal and child health and evaluate them using administrative data. So in order to understand how interlinkages of policies can modify the determinants of adverse child health outcomes, MatCHNet was focusing on 3 sort of policy intervention periods during the early child life course. So in pregnancy, in infancy, and then in the preschool period up to about sort of the age of 6 or 7. And these policy interventions period lie within policy landscape, and that policy landscape may differ across the 4 UK nations. And within these policy landscapes, they've got different policy departments which may impact the health outcomes. And cutting across the intervention periods are the linked maternal and child data sets within each country, and they have the potential to create whole country longitudinal birth cohorts that we can then start to look at some of the health outcomes. But this also opens the potential for data sets from different sectors to be linked into the birth and the health data. And we have the stakeholders and who come from different, as well as different policy sectors. There's different sort of methodologists and different topic areas and different stakeholder interest groups that need to come together to feed in to all of this as well. So we really need kind of all of these areas to come together. So we've got in-depth knowledge about the policies, in-depth knowledge about the administrative sort of data timelines that are available, and the measures that are available, and also to understand much more and to develop the evaluation methodology to evaluate these policies. So that's kind of where MatCHNet came from, and that was our sort of like starting point. And then we developed our research manifesto during our first year in consultation with network members, and then that really refined the manifesto, and that proposed, so our research manifesto proposed 3 challenge areas that the network needs to address, and they are to understand the policies that vary across the 4 UK nations, then prioritise these national policies so that any research is relevant for the users of research. We also wanted to understand the administrative data that's available and comparable across the 4 UK nations, and as I said, then use sort of appropriate methods to evaluate the policies. So that's the kind of the why, I suppose, of MatCHNet. Now on to the what. I'll give you a flavour of some of the activities that we've undertaken to make progress against these challenges. And much of the output of our activities are available on the MatCHNet website. The link is there on the slide. We do run, I think, one of our sort of key outputs or key activities is a very successful webinar series on policy evaluation, is really just to kind of showcase the types of evaluations that we would be able to do once we've understood the policies and we have the administrative data in place. And within those webinar series, we note the implications for policy and practice. And we also have running sort of alongside that a series of methods workshops that can upskill that sort of maternal and child health research community and also the policy and practice community, so that they're kind of understanding what methods might be appropriate to use, and if they're reading the research, whether they feel that the methods have been carried out appropriately to evaluate the policies. We've also funded a number of pump priming projects that carried out sort of proof of concept and some evaluability assessments of the policies and some data mapping. They scoped out the data to understand what administrative data are available. And one of the main things we did was a policy prioritisation exercise, and I'll go into a little bit more detail about that one. Before I go into the detail about the policy prioritisation, a shameless plug for MatCHNet. We've got an upcoming webinar. The next webinar is on the 29th of October, and that's discussing the Born in Bradford, Born for All data sets, and talking about some of the policies that they're able to evaluate in that, looking at perinatal mental health. So if you're interested, have a look at our website for more details. So onto the MatCHNet policy prioritisation, that was tackling the first challenge area. So really, like, what are the policies that we should be evaluating, that need evaluating? And the full paper is available in the Archives of Disease of Childhood. I'll just take you through a short summary of what we did. So we conducted a systematic search of all the policies that were relevant to child and maternal health. Our research was guided by the social determinants of health framework. So search focused on policies in the areas of welfare, employment, health, housing, education, and the environment. And really the rationale behind this was that we want to identify all policies, not just the child health focused policies. And out of the 336 policies that we found in that systematic search, we had sort of filtering and exclusion criteria, and 183 were excluded based on some of these criteria that we developed around really sort of usefulness to be evaluated at a national level. So it might be that the policy wasn't able to affect, it wasn't implemented across the whole of the UK, or wouldn't be able to be implemented across the whole of the UK, so it didn't really have that variation that we could look at. And then a further 65 were removed due to duplication or being a bit outside the remit. So we had 88 policies being included as potential candidates for future evaluation. And so these 88 policies then went to an expert group with child health, administrative data and evaluation experts, and then to the policy and advocacy stakeholders through workshops and an online poll. And we narrowed that field down to 3 areas. And we produced policy briefings and reports for these 3 areas of early years education and childcare, maternity grants and universal credit. So that's a sort of brief summary of some of the activities that we did in MatCHNet. So now on to the kind of like the where next and where we might take some of this work. So I suppose it's really getting on to the sort of what we learned from MatCHNet. And these key learnings are that it is in policies that are in sectors other than health and health services that the policy and advocacy groups prioritised, and really to evaluate those policies properly or to conduct these sort of like rigorous evaluations, we need to link data from the other sectors to the health outcome data. So we can't just use health data, we need to have that cross-sectoral linkage of the data, and underpinning that is using these rigorous evaluation methods. So just in a bit more detail what I mean about that. So I suppose we've talked a bit about the identification of policies. They're not necessarily in the health and the health policy area. You know, the determinants of the infant and child health are the same as the determinants of all health, which is the social determinants of health. So many policies that might affect the early years are going to be from, as I say, these other government departments. And this is where I think the sort of cross-sectoral linkage and administrative data really does hold a lot of promise. To undertake these rigorous evaluations, we need to be able to identify both the exposed group and also a suitable comparison group. So who's exposed to the policy, who's the policy meant to be working for, and then what is a good control group for those people. And that can be quite difficult at the population level, as I say, when health records are not linked to exposure data. So for instance, welfare policy, if health data isn't linked to welfare policy, how do we know who's exposed to the policy? You know, we can think about ways of using eligibility criteria to construct that exposed and control group. And also we can think about trying to identify a wider group. So it might not be people who necessarily receive the dose of the policy, but just looking at a wider group people who might have similar characteristics to those of the eligibility criteria. So for instance, if policies are aimed at supporting teenage mothers, we might be able to, in our administrative data, identify teenage mothers, but we don't necessarily know that they've been exposed to a policy that was particularly for teenage mothers. So kind of thinking about that as an intention to treat analysis of about how the policy's working in practice, but that might not be good enough for a complete, robust evaluation. As I say, like the data collection for policy evaluation can be difficult, and you know, to evaluate a policy that's already in place, it's nearly impossible. You can't retrospectively really go back and survey people, and that's, I think, where administrative data really sort of come into its own. They can span families, they can span life course, they can span across disciplines, and they can really be used then to evaluate such policies. And you know, having the data, I think I've probably said this too much, but having them linked across the policy sectors really is that sort of like vitally important. We need to know the welfare status or the educational provision and outcomes for children really to evaluate these policies properly. And to look at population level impacts of national policies on the kind of long-term health outcomes and inequalities, we can't really examine that in trial settings. You need to use other methods of evaluation, such as natural experimental designs and other evaluation methods. And as well as outcome evaluations, you'd really need to do that economic evaluation alongside. Heckman makes that convincing argument about the earlier you spend in the life course, the better value for societal benefits, but really should test this and do the economic evaluations. So just really finally to think about what some of the implications and impact and what we might do, really just to seed some thoughts for you to take into the breakout discussion rooms. Let's think about what the implications of these learnings are. I think there really is this need to have the data from other sectors linked to health data. I know that you shouldn't start with your research question from what data you've got to look at, but we've developed quite a lot of research questions there and the different policies we want to evaluate. And really, I think key underpinning that is this need to link data from other sectors into the health data. From MatCHNet, we've learned that the policies that could have the biggest impact on maternal and child health are, and also the ones that the stakeholders prioritise for further research and evaluation, are in sectors other than health and health services. So we really do need that linkage across sectors to identify the target population. So those who actually get the policy dose, we need to know about uptake information and also be able to identify suitable control groups. And this is all leading to needing a better evidence base. In our policy prioritisation, many of the impactful policies were excluded due to lack of appropriate data to undertake any meaningful evaluations. So we might have been able to include more policies, and different ones might have been prioritised if there were better access to that cross-sectoral linkage of administrative data. And currently there have been few either experimental or natural experimental studies examining differential effects of interventions or policy changes by socioeconomic circumstances. So that can lead to the inverse evidence law, whereby the sort of least research on the intervention is most likely to have the largest population health impact. I still think there's, we need to remind people that child health is important for adult health. So child health now is important for future health benefits. And if we get it right in infancy, then that can track through to adult health. As I said, the determinants of infant and child health are affected by the kind of like macro level policies, and all have the potential to improve the health of the mother, the index child that you're looking at, subsequent children, and possibly the rest of the family. And then that will, ultimately reduce the health burden in later life. So it really is important to have the right policies in place to allow children to have the best possible start in life. And it's how do we know that these are the best policies? There is a willingness across the governments to spend in this area, but we really need to have that robust outcome evaluations of policies to ensure that money is being spent on the right policies that will improve health and lead to that reduction in health inequalities. And finally, I'd like to acknowledge the funders and also thank the co-investigators and members of MatCHNet, in particular Emma Stewart for all her work, and the MatCHNet co-investigators for conversations that shaped the idea in this presentation. So thank you all for listening to me, and if you want further details on MatCHNet, please visit our website or follow us on X. Thank you.
Thank you very much, Ruth. That was excellent. So some of the seed corn funding from MatCHNet funded us to put together MIREDA, which is a mother and infant research electronic data analysis. And that is trying to use OMUP, common data model, to harmonise the born in Bradford data, the born in Scotland, born in Wales, born in South London, and MumPredict. And MumPredict is CPRD data for England, both gold and my brain's gone blank now. The Orium, is that right? Now, so I'm just going to say a wee bit about what is MIREDA, what have we done so far, funding to work with this data set, and looking to just say about the advisory committee. So this is some of the people in MIREDA who are helping to sort of harmonise the data. So you may recognise some people here from South London and Bradford and HDR UK. So it's really trying to create a UK-wide birth cohort, harmonising the maternal and infant data, and creating a core that can then be linked to local data sets like the census, like health visitor data, education data in the different regions, and primary and secondary care data. And the idea is really to be able to do natural experiments and compare one area with another area without needing to move the data. So each cohort puts their data in the OMOP Common Data Model, so that a script can be sent to each region and run there with aiming at a federated analysis where the answers can then be brought together or compared with each other. And there should be a dynamic longitudinal birth cohort for UK using electronic data. The protocol has been published recently in the International Journal of Population Data Science. And just to give you an idea, Born in Scotland is just at its pilot stage and is now starting to recruit having gone through the pilot. You can see here that there are big differences in different regions. So if you take just in England, if you look at born in South London, the chance of a baby being preterm, there's about 9.6% of babies are born preterm. Whereas if you look at data in the ORAM in CPRD, in other areas, it's 6.2, or if you look in the Born in Bradford data, it's 6% are likely to be preterm. So I'm comparing with like the data from Gold and CPRD, which again is quite high. This gives us the opportunity to look at differences and really look at natural experiments to what works in different regions. So we have a core data set, which is information about the pregnancy and information about the birth. This is then linked to follow-up for the mum and the infant to look at the GP data, the hospital data, the health visitor data, and that's for all the cohorts. And then in some regions, we can also link to education, we can link to social care, we can link to the census, for example, in Wales. OMOP gives the same structure to all the different data sets, and then it maps to common vocabularies like class, the concept, the domain, and basically where it's come from. So whether it's a SNOMED code, a READ code, or a text code. So what you get really is a different code depending on where it's come from, but it's a harmonized code that if you've got the sort of data dictionary for OMOP, you can then put these codes together and they'll all identify gestational diabetes. Now, not everything can be standardized that easily. So the ethnicities that are captured are quite often different in different areas. So although we're basing ours on the 2021 census ethnicity categories, they're not the same in each country. So for Wales, we have codes for British, Irish, Gypsy, Traveller. Those codes aren't broken down like that in other countries. In Scotland, there's a code for a Polish background code. Other nations don't have this. There's an Arab code in Wales, which isn't in England. And the term Chinese is sometimes coded as Asian, Asian British, other ethnicity Chinese. Sometimes Asian is broken down to South Asian or other Asian. So depending on area, they are already classified different. So we need to standardize these before OMOPing, which means we will lose detail. And obviously, these are the codes for the mum. And baby's ethnicity or race is a mixture of their parents, and that actually may be quite difficult to do. So the ethnicity end of things will be quite hard to standardize. Now, within our funding, we have 3 pots of 20,000 each for people to enable people to come and work with the data set and work with us on this. Possibly improving some areas, developing training models, writing a grant that uses the data set, working internationally with other people who have OMOP'd their data. And we're going to have a workshop in February, which is with the DOHAD, so the European Group for International Society for the Developmental Origins of Health and Disease. We'll be able to say a bit more about applying for the seed cord funding to use this data set. Like I said, this came from working with MatCHNet, and we obtained seed cord funding from them. We're also, so in order to develop the workshop and inform where the funding should go, we're hoping to put together an advisory committee. And I wanted to ask if anybody would be interested and be willing to be part of the advisory committee. That would help. It would be really to inform the design of what the workshop needs to look like, who should be invited really, maybe to talk or present. It's at a 1-hour meeting on the 29th of November. And it would also involve reviewing any applications. So it's just to ask if anybody was interested in being part of the advisory committee, to really get in touch and let me know. And so that's just an overview of the MIREDA work that's going on. Thanks very much for joining.